Good morning, friends. Let me at the outset thank the Scientific Committee of AIOCs for giving this wonderful opportunity for us for doing this course again. We have done this in the AO, ASCRS, ESCRS, the IOL fixation techniques. I am Dr. MOHAN RAJAN. I am the course director, and I'll be talking on conquering PCR. And you know, Dr. Amar Agarwal doesn't require any introduction. He is going to talk to us on glued IOL tips and tricks. Sujata Mohan will be talking on sutured scleral fixation management of subluxated IOLs as well. Manoj Khatri will be talking on dropped IOLs. And Nivian Madhivanan from Chennai also will be talking on iris claw lenses. So once you have a PCR, there are different options which you have to keep in mind. And I'm going to talk about the next 12 minutes about this conquering PCR. And these are my financial interests, which doesn't come in the way of this thing. Anybody in the audience have not had PCR? Yeah. That day I was presenting in Amritsar, and one of the guys, when Sardaji put his hand up and he said, I have not had PCR in my life. Then I found out he was an ENT surgeon. So he has come there because his wife was an ophthalmologist. So if you don't have PCR, probably only two reasons. One is you are telling lies. Number two is you are not operating at all. So no surgery is complication free, as I know. Neither any surgeon can claim any complication. It's skill in the management which actually makes you the difference between an ordinary and extraordinary surgeon, how you bring the best out of a PCR. Early recognition combined with advances in instrumentation have enabled effective management of PCR rupture during phacoemulsification. So you can see here this that when you anticipate PCR in a cases of a traumatic cataract, post-vitrectomized eyes, posterior polar cataract, hard-bound cataracts, just now we were discussing about it in the previous course, and also pseudo-exfoliation. So you need to anticipate PCR, so you probably have a plan A, plan B, and plan C when you operate on these patients. Stage at which the PCR rupture can occur during hydrodissection, during nucleus removal, any part during cortex removal. It is the most common, especially for the beginners, because we are having a very high vacuum and the posterior capsule is not protected because of the high vacuum you are using. And during posterior capsule vacuuming, polishing, or during IOL implantation as well. What are the early signs? Sudden deepening of the anterior chamber, loss of lens followability, lens tilt or deepening of the posterior chamber. Amar, I request you to come on to the dais, please. Thanks, Amar. You can see here, this is one of the patients. You can see here, there is a sudden deepening of the anterior chamber and the posterior chamber. You can see that the loss of lens followability. Suddenly, the lens does not come into the tip, despite the fact that they are increasing the aspiration flow rate in a peristaltic mission. You can see here in this particular case how there is a sudden deepening. Can you see that the sudden deepening is there? This is what I think we have to recognize, that there is a PCR, and probably take action at that point of time. Probably remove the vitreous to the pars plana to the rhombus, because obviously when there is a PCR, definitely you need to put tricot there, find out. So just inject viscoat and come out of the eye. Viscoat, I don't have any financial interest, but viscoat is something which is which really plugs the PCR. So when you have a pupil snap sign, that is the first telltale sign. There is a sudden contraction pupil during hydrodissection. So what are the conditions you need to avoid hydrodissection? Yeah, I know everybody does hydrodissection on a regular basis. I do hydrodissection on a regular basis for all cataracts. Hydrodelineation I do only for these cataracts. No hydrodissection. That is posterior polar cataract, traumatic cataract, previous vitrectomized eyes, and also nowadays we have a lot of patients coming with repeated intravitreal injections. Please understand, these are all patients are very likely to have a inadvertent PC tear. Sometimes there can be a lens touch, especially when this thing is given by one of your residents or somebody. You have to be a little careful about it. So this is again a case 2. You can see here, I didn't recognize there is a posterior polar component. You can see that the nucleus is going into the vitreous cavity. There is a hydro rupture probably. There is another patient. You can see a very dense nucleus, and probably my assistant puts heavy viscoelastic on the cornea and pushes the nucleus into the vitreous cavity. So this can happen. So this hydro rupture is something which you need to, you see, every time you hydro dissect, okay, you need to decompress the nucleus into the back. Why? Because you don't want the pressure to build up in the cavity between the nucleus and the posterior capsule. You can have a blowout. It's called acute capsular blowout, and even as soon as you put your phaco probe, you will see the nucleus is going into the vitreous cavity. So you have to be very, very careful, especially when you have a small rhexis and a huge cataract. Small rhexis, you can be careful in decompressing and also making sure that you decompress the nucleus into the bag. If you have a small PC tear, convert into a posterior capsular. Why? Because the posterior capsular rhexis has got a better strength than your PC tear. Okay? If you have a small PC tear, convert into a posterior capsular rhexis, and you can go ahead and put a lens in the bag without the fear of the PC tear extending. Otherwise, if you have PC tear and try to put a lens in the bag, that tear will start extending, and you will lose the lens into the vitreous cavity. If not on the same day, next day you will find it on the macula. So that is what I think you should be very careful. If it's a small PC tear, convert that into posterior capsular rhexis. Okay, everything, this happened to me. This happens to everybody. Okay, when you have a PC tear, you can see here, you become jittery because you may be operating on a VIP or a doctor. You become jittery. You have a PC tear. You can see that the nucleus is also going inside, and okay, and don't pull out. If you pull out, what will happen? If you pull out, the entire PC tear, what is a small PC tear, will become a huge PC tear, and the vitreous is like a tsunami. The vitreous will start coming into the anterior chamber, and this is what will happen. Immediately I went bimanual, and once you have a PC tear, you need to shift to the bimanual. Bimanual means the irrigation is separate from this thing, and pray to God. If you pray to God, the nucleus will come up, depending on the karma. Depending on the karma you do. I have see a lot of Bangladesh doctors here. Inshallah, you say at that time. Okay. Avoid removal of instruments quickly from the eye, and introduce viscoelastic through a side port. Come to positions. That's what you should do. When you have a PC tear, this is a patient. Okay, this is one of the members of parliament I operated a long time back. These politicians commit a lot of sins and come to us. You can see here, you can see here when doing the last nucleus piece, there is a beautiful PC tear. It's a beautiful PC, just like Aishwarya Rai Bachchan yesterday, and there's a beautiful, nice posterior capsular rhexis. But I didn't lose my calm. Okay, what is important is when you have a PC tear, inject Viscoat. Viscoat, I don't have any opinion, but Viscoat is probably the best. Okay, of course the Indian companies will also come out. The Viscoat, see how it's going and plugging that PC tear. Inject Viscoat and slowly stabilize the anterior chamber and slowly come out of the eye and shift immediately to bimanual. Create a right side port, immediately bimanual. Because if you have a unimanual or a coaxial, if you have PC tear, coaxial means the irrigation and aspiration are on the same port. Okay, if you have an irrigation aspiration and you have PC tear, what will happen is more and more vitreous will start coming in because it will hydrate the vitreous, and the PC tear, what is a small PC tear right in front of your eyes, within a few seconds the PC tear will become a huge PC tear. I will not be able to put a lens in the bag. So when you have a bimanual, what happens is bimanual is if you go into you can see here, this is again a PC tear during removal of the epinucleus, and then what I do is I inject, as soon as I inject Viscoat and come out and immediately shift to the bimanual. Always remove the vitreous first and then remove the cortex. Don't be in a hurry to remove the cortex and the epinucleus. Remove the vitreous first and then remove the cortex. Okay, use tricot because this vitreous is a colorless substance. Even God cannot see the vitreous. Okay, I'm telling you. Okay, vitreous is a colorless substance. Unless you put preservative-free tricot, that diluted, you can put that, and then you can see, delineate the vitreous. You can see here, I'm delineating the vitreous, and and making sure that the vitreous, you don't have to be a posterior segment surgeon. Okay, you just remove the vitreous which is there in the anterior chamber. Once you delineate the vitreous with a tricot, just go in and remove the vitreous, and you can have a separate irrigation and aspiration. If you have a separate irrigation aspiration or separate irrigation and cutter, that will prevent the hydration of the vitreous and also cut only the vitreous which is there necessary. You can do the pars plana as well. You can see this is a posterior polar cataract. I can see what is happening. I am trying to remove the epinucleus and see how it's saying. But I don't lose my calm. I'm injected Viscoat and I was on coaxial, and immediately I put tricot, and you can see I am removing the vitreous. Don't be in a hurry to remove the cortex and epinucleus. Why? Because in the presence of the vitreous in the anterior chamber, if you try to remove the cortex and the epinucleus, every time you remove the cortex and epinucleus, there will be traction on the vitreous base, and these patients are likely to have retinal breaks and retinal detachment in the postoperative period as well. So again, you can see here another patient which is again epinucleus, a posterior polar cataract. So what I am doing to do is I am trying to put the tricot there and remove the vitreous and then remove the cortex, all bimanual. Bimanual means don't use the main port, the left side port, the right side port. Left side port is irrigation. Many of us are right-handed surgeons, so right side port is the cutter or the aspiration. The irrigation always will be in the eye. Okay, you keep changing the cutter, or you can have the IA cut or the cut IA, which is there available in all the phaco machines nowadays. You can see here, there is another patient. You can see here how I am removing the vitreous. This is a posterior polar cataract. You can see here, this is a posterior polar cataract. I am doing a rhexis, making sure the rhexis is about 5 millimeter, not very big, not very small. Why it's not should not be very big? Because if you want to capture the IOL, this thing, you can see I am doing only a hydro delineation. Look for the golden ring sign. This is very which is very important. I am doing a slow motion phaco. I am not trying to rotate the nucleus, and you can see here as I am trying to, you can see that plaque on the posterior nuclear plate which is there. I am injecting viscoat into the anterior chamber and coming out of the eye, and then going ahead and doing a coaxial irrigation aspiration. At this point of time, I notice there is a PC tear. You can see I am withdrawing, I am injecting viscoat. I am not withdrawing just like that, I am injecting viscoat, and then immediately I am shifting to the bimanual. Okay, I know there is no vitreous there, but I should have actually using, then I go ahead and do the anterior vitrectomy. And this patient I didn't use tricot because the patient had family history of glaucoma, and this he had also had ocular hypertension. So that is the reason why I didn't use. Again, injecting viscoat, coming out of the eye, shift from the right side to the left side, access the thing. I'm making sure that the vitreous is not there when you remove the cortex, and then going ahead with the lens implantation. You can see here I'm putting a multi-piece lens in the sulcus. I'm putting a multi-piece lens in the sulcus, and then don't leave it in the sulcus. This is the message I want to give. Don't leave this multi-piece lens in the sulcus. Why? Because if you leave it in the sulcus, there's a possibility of a long-term decentration and long-term UGH syndrome. So always capture this lens. You can see here I am capturing this lens into the capsular rhexis margin. That is the reason why it's important that you have this thing. Again, you can do a pars plana anterior vitrectomy also. I am trained in both anterior and posterior segments. It doesn't matter. You just have to put a trocar and cannula measuring about 3.5 millimeters into the limbus. You can see here, put the anterior ACM in the anterior chamber maintainer. Amar has devised a beautiful trocar anterior chamber maintainer, which also I think you will be talking about. You can see here I am trying to remove the vitreous from behind. It's not easy to put a trocar and cannula. Always make sure the anterior chamber is tight before you do that. Then once you do the EPC there, then you assess the sit back and relax, because your adrenaline is flowing. You don't want to put a lens which is going to go into the vitreous cavity. Make sure that your capsular rhexis is good enough, and to put a multi-piece lens. If your capsule is the posterior capsule is good enough, you can probably put a single piece lens, provided you converted that into a posterior capsular rhexis, as I told you before. So just to show you, this is a patient again which long time back I did. There is the capsular support. Always make sure that you put the lens that is haptic. If the pupil becomes small, for heaven's sake, please use iris hooks, because many times when you have PCR, the pupil becomes small and you put a lens and next day you find the lens on the retina. So what is happening is you need to make sure, because pupil will become small because when you have PCR, lots of prostaglandins are getting released in the eye. Put iris hooks, take some more time. If you are on topical anesthesia, you can just give a subcutaneous anesthesia, making sure the patient is comfortable, and all these problems can get sorted out because of this. So you can see this glued IOL and other things which you are going to do this thing. This is an anterior assisted levitation. You can see here the PC, the nucleus does not go into the vitreous cavity. It's there in the pupillary area. You can do what is called the AL. That is called the anterior assisted levitation. Anterior levitation. Only thing is, don't do it in very very young patients. This is a very old patient, cardiomyopathy. I went ahead and then I put a tricot again. I'm making sure that I put an anterior chamber maintainer, removed the thing. I went ahead with an anterior chamber IOL, and this patient did very well. Again, a posterior assisted levitation also, again, wherein you can go in and do a posterior assisted levitation. Don't do it in young patients and eye myopes. So this is the message I want to give. When you have a PC tear, stabilize, come out, go bimanual, remove the vitreous first, remove the epinucleus and the cortex later, assess the capsule, sit back, dilate the pupil if necessary, and then prevention of PCR, early recognition, good vitrectomy, bimanual techniques are all very important. Otherwise, you will have a sorry state of affairs like the baby on the right. You can see here, and this PCR patient will take the life out of you. Thank you very much for the wonderful opportunity, the patient attention as well. If you have any questions, we can discuss before we go to Dr. Amar Agarwal, who is a stalwart in glued IOLs. Any questions from the audience on PCR?
Any comments, questions from the audience?
डायरेक्ट लगा देना, ये निकाल दे, ये निकाल दे, इसको बंद कर देना, बंद करना.
So when we have a rupture, like how do we decide? Do you remove the cortex first and then the vitreous, or you said in one of the cases that it is better to remove the vitreous first before doing the cortex aspiration?
Always remove the vitreous. Always remove the vitreous which is there, because as you know, when you have a PC tear, most likely there will be vitreous in the anterior chamber. The only way to delineate is once you have a PC tear, inject viscoat come out of the eye, okay, and introduce preservative-free diluted tricot. Then you find out if there is no vitreous, probably you can put viscoat there and probably go in and remove the nucleus and the cortex using a bimanual technique, using a low flow, low bottle height, everything. So once you see that vitreous is there, then always go in and with the cutter, and then go ahead with the anti-vitrectomy, and then subsequently remove the